All right, let's dive right in. Today, we are tackling the really complex world of hereditary neuropathies. What are they? How do we even begin to classify them? We're going to break it all down, and we'll use one of the most important examples out there, Charcot-Marie-Tooth disease, to guide us.
So here's how we're going to tackle this. First up, we'll get a taxonomy, a way to sort all this out. Then we'll do a deep dive into our main case study, Charcot-Marie-Tooth disease. From there, we'll take a quick tour of some related conditions, and then we'll wrap it all up with the key diagnostic clues you absolutely have to remember.
Okay, first things first. To even begin to make sense of this stuff, we need a framework, a way to organize our thinking. This is the foundation for everything else we're going to talk about today, so it's super important.
So, what are we actually talking about here? Well, at the most basic level, hereditary neuropathies are exactly what they sound like. Genetic disorders you inherit that damage your peripheral nerves. Think of these nerves as the body's wiring, the communication highway connecting your brain and spinal cord to, well, everywhere else. When that highway gets damaged, the signals just can't get through properly.
Okay, this slide is absolutely key. It's what I call the rule and exception framework. And if you get this, you're halfway there. So, nerve damage basically comes in two flavors, right? You've got axonal, where the nerve fiber itself is the problem, and demyelinating, where the insulation around the nerve, the myelin sheath, gets damaged. Now, here's the general rule. Most hereditary neuropathies, they're axonal, and most acute neuropathies, they're demyelinating. But, and this is the important part, it's the exceptions that really define the field. We're going to be talking a lot about CMT1 and Refsum's disease. Why? Because they break the rule. They're hereditary but demyelinating. On the flip side, we'll look at porphyria, which is acute but axonal. Seriously, understanding these exceptions is the name of the game for diagnosis.
All right, let's put this framework into action. We're going to zoom in on our main case study, Charcot-Marie-Tooth disease, or CMT for short. It's the most common one you'll encounter, so it's really the perfect example to unpack all of this.
So right away, CMT splits into two main types. You've got CMT1, that's the common one, and it is demyelinating. This is where you see that classic textbook finding on a biopsy, the onion bulb. What's that? Well, it's literally what happens when the body tries to fix the damaged myelin over and over again. It just keeps wrapping new layers, and it ends up looking like an onion. Now, CMT2 is different. It's axonal. The nerve fiber itself is degenerating, so you're not going to see those onion bulbs or the thickened nerves you get with CMT1. Even though they're different pathologically, they're both usually passed down in an autosomal dominant way.
Okay, that's the pathology, but what does this actually look like in a real person? Let's talk about the clinical picture. How does someone with classic CMT, let's say CMT1, show up in the clinic? What's their story?
The number one thing you have to understand about CMT is that it is slow, incredibly slow. We're not talking about a history of weeks or months. When a patient comes in, their story often stretches back decades, 10, 20, even 30 years. It's so gradual, so insidious that people just adapt to it over time. They might not even realize something is truly wrong for a very, very long time.
And this leads to one of the most fascinating things about CMT, a real clinical paradox. You'll ask the patient, do you have any numbness, any tingling? And they'll almost always say no. They don't complain of sensory symptoms. But then you do your exam and bam, the signs are right there. You test their proprioception, their sense of where their limbs are in space, or their vibration sense, and it's clearly impaired. No symptoms, but clear signs. It's a classic feature.
So what finally brings them in? A lot of the time, it's not even the weakness. It's that they notice their body is changing. They develop these really classic physical signs. You'll see pescoveus, which is a very high-arched foot. You'll see hammer toes. And then there's the most iconic sign of all, the inverted champagne leg. It's such a vivid description, right? It's because all the muscles below the knee have wasted away, making the lower leg look skinny, like the neck of an upside-down champagne bottle. On top of that, you can often feel their nerves because they're so thickened, and you can bet their ankle jerk reflex will be gone. It's just universally absent.
All right, so that's our deep dive on CMT. Now let's zoom back out. Using that framework we built at the beginning, we can do a quick tour of some other important hereditary neuropathies and see how they stack up against CMT.
First up, familial amyloid polyneuropathy, or FAP. Now this is also an axonal neuropathy like CMT2, but the cause is totally different. Here, the problem is a mutation in the transthyretin gene. This causes a messed up protein, amyloid, to get deposited in the nerves, and that's what causes all the damage.
So how do you spot FAB? There are three huge clinical clues. One, the autonomic nervous system gets hit, and it gets hit hard. We're talking major issues with things like blood pressure, digestion, you name it. Two, this is not like CMT. FAP is a painful neuropathy, really significantly painful. And three, it doesn't pick and choose. It goes after both the large and the small nerve fibers.
Okay, next on our tour, the porphyrias. Now these are actually a whole group of metabolic disorders, but for our purposes, we're focused on the three types that can cause neuropathy, and they're all autosomal dominant: AIP, variegate, and hereditary coproporphyria.
And the neuropathy you get with porphyria is weird. It's got a really unique signature. Remember that rule and exception thing? Well, here's our star exception. It's an acute, meaning it comes on fast, but axonal neuropathy. It's almost all motor, and here's the strange part. The arms are often weaker than the legs. The whole system can be involved: autonomic, peripheral, and central nervous systems. And you see this scary, rapid muscle wasting. It's a very dramatic presentation.
All right, let's talk about a really rare one, Tangier's disease. This is autosomal recessive, and the problem is a defect in a protein called the ATP-binding cassette protein. What does that do? Well, the big result, the thing you'd see on a lab test, is that their HDL, the good cholesterol, is practically gone, just wiped out.
This one has probably the single most memorable clinical sign in all of neurology. It's what we call pathognomonic, meaning if you see it, you've made the diagnosis. The patient has these huge, bright orange tonsils. It's just bizarre. That's from all the cholesterol building up. The neuropathy itself is axonal, but it has this really weird pattern for a genetic disease. It shows up as an asymmetric mononeuropathy, meaning it hits one nerve on one side of the body at a time. Super unusual.
Okay, let's get back to our other major rule breaker, Refsum's disease. This is our second big example of a hereditary neuropathy that is demyelinating. The problem here is a metabolic one, a glitch in something called alpha oxidation. Because of that glitch, a toxic substance called phytanic acid builds up, and that's what absolutely shreds the myelin.
And how do you spot Refsum's? It's all about the classic triad. If you see these three things together, you have to be thinking about it. Number one, retinitis pigmentosa, which messes with their vision. Number two, cerebellar ataxia, so they have big problems with balance and coordination. And number three, the peripheral neuropathy we've been talking about. That triad is your huge clue.
Last one on our tour is Fabry's disease. We're back to an axonal neuropathy here. And if you had to describe Fabry's in just a few words, it would be pain and autonomics. The pain is intense, coming from the small nerve fibers, and the autonomic problems are severe.
So the big clues for Fabry's are this combination of what you see on the skin and what the patient tells you about their pain. You need to look for angiokeratomas. They're these little dark red spots on the skin. And you need to listen for them describing acroparesthesias. That's this awful, severe, burning pain, especially in their hands and feet. It's excruciating.
Whew, okay, that was a lot. So let's bring it all home. Let's boil everything we've talked about down to a simple, high-yield summary. The key diagnostic clues you can't forget.
This chart really says it all. Let's run through it. For CMT1, our demyelinating example, you're thinking onion bulbs and inverted champagne leg. Easy. For FAP, which is axonal, the one-liner is painful neuropathy plus severe autonomic problems. Got it. For porphyria, our acute axonal one, it's that rapid motor wasting combined with things like abdominal pain. Tangier's, axonal, that's the easiest one of all, orange tonsils. Done. Refsum's, our other demyelinating condition, that's the triad, retinitis pigmentosa, ataxia, and neuropathy. And finally, Fabry's, another axonal one. You see those angiokeratomas and hear about the awful burning pain, the acroparesthesias, you're there.
So that brings us to one last thought to leave you with. We've spent this whole time classifying these conditions based on what we see clinically and pathologically. But here's the thing, genetic testing is exploding. We can now find dozens, even hundreds of different genetic variants for what we call a single disease, like CMT. So what does that do to our old definitions? At what point does a disease stop being one thing and start being hundreds of different things? It really makes you wonder. And it's a question that's totally reshaping how we think about neurology, moving us away from just clinical labels and towards a true molecular understanding of disease.